Today we are going to have a short webinar on Neprilysin pathway in the heart failure. I am Dr. Jyotsna, working as Professor of Cardiology in the Nizam Institute. Actually, what is the need of starting sacubitril valsartan in a patient of a heart failure? If you see the previous studies, especially which is quoted very well and published in the American Journal of Heart Association 2012, is when we go on add the therapies to the congestive heart failure patient with the existing ones, beyond a 4 to the 5 therapies, almost it reaches to the plateau. It means to say that when only the beta blockers are given, there is a reduction about 38%. When the ACE inhibitors or ARBs added, it is a further reduction is occurred. Whereas in addition, ASA is added, further reduction occurred. In addition, if you added to that of an anticoagulation, further is added. But a further addition of any more, like the CRT or anything, is not further decrease the mortality rates. That means to say that the plateau will be reached after a 4 to 5 therapies union of all armamentarium for the control of the congestive cardiac failure. So then the need of the other therapies has come, and really the Neprilysin inhibitors worked very well in this field. The major novel mechanism of an action of ARNI is a first-class angiotensin Neprilysin inhibitor is mainly it acts on the Neprilysin system as well as in the RAS system. It has a combination of the two drugs of angiotensin receptor blocker and Neprilysin inhibitor. So in the natriuretic peptide system, mainly it causes the positive effects of remodeling effects in the heart. Mainly it causes increases the natriuresis and decreases the renin release and causes the vasodilatation, decreases the blood pressure and decreases the large artery stiffness and decreases hypertrophy, fibrosis, as well as the sympathetic outflow is decreased. Whereas the RAS system activation causes the opposite effects, causes the sodium in the water retention, vasoconstriction, increase in the blood pressure, vascular remodeling, hypertrophy and fibrosis, and sympathetic outflow is increased. These natriuretic peptides have a potential benefit actions in the heart failure. The major important natriuretic peptides are available are atyl natriuretic peptide, BNP and CNP. A CNP mainly from the vasculature, whereas ANP and the BNP are released from the heart. The major effects of the natriuretic peptides on the human body is it decreases the sympathetic outflow, decreases the vasopressin, and decreases the water intake, as well as it causes the increased sodium loss and decreased aldosterone levels and decreases the renin levels. In addition, it causes the decreased hypertrophy and decrease the fibroblastic proliferation. The positive vasodilatory effects causes decrease in the systemic vascular resistance, decrease in the pulmonary arterial pressure, and decrease the pulmonary capillary wedge pressure, and decrease the right atrial pressure, which causes the relief of pulmonary edema symptoms to the patient. The major one is Neprilysin inhibition potentiates the action of endogenous vasoactive peptides. Usually the endogenous vasoactive peptides are natriuretic peptides, adrenomedulin, bradykinin, substance P, calcitonin gene-related peptides. These are degraded to inactive metabolites by the Neprilysin. When we inhibit the Neprilysin, all these endogenous vasoactive peptides are very active and causes a decreased neurohumoral activation and decrease the vascular tone, cardiac fibrosis and hypertrophy is decreased, and sodium retention is decreased, which has a positive effect in the case of the heart failure. The major studies are done on both in the systolic dysfunction cases as well as the diastolic dysfunction cases leading to the heart failure. The predominant and the very famous paradigm heart failure study has demonstrated the efficacy of this ARNI in the case of reduced ejection fraction. There are the two other studies done with the diastolic dysfunction related heart failure, that is relatively preserved ejection fraction patients. These two studies are the Paramount and the Paragon HF. The Paragon HF, which is released in the March 2018, has shown a positive effects. In this, The S by V is improved in the global circumferential, but no longitudinal strain is improved at 36 weeks, despite of improvement of the patient's symptomatic status. The Paragon HF is still ongoing till the end of the May. They recruit the cases, and probably it is expected to release its results later. The Paragon HF trial has demonstrated that the RNA has a overall more efficiency than when compared to the enalapril, which is very, very statistically significant. And what are the basic differences in between the sacubitril and isolated enalapril? This is the table taken from that of the Paragon trial itself, and it is demonstrating that both the adverse events are almost similar in the sacubitril and enalapril, whereas the hypotension is more with the sacubitril valsartan group than with the enalapril group, and a cardiac failure improvement occurs much better with the sacubitril, and hyperkalemia is less with the sacubitril than with the enalapril, and the renal impairment is less with the sacubitril than with the enalapril, and the cough is more with the enalapril and less with the RNA, and the dizziness is more with RNA than with the enalapril, and atrial fibrillation is almost similar, and as well as the peripheral edema is almost similar in the both groups. Depending upon this paradigm HF trial, 2016 ESC guidelines has given a class 1 indication to start the RNA. And not only that, the RNA is recommended as a replacement for the ACE inhibitors to further reduce the risk of the heart failure, hospitalization, and death in ambulatory patients with reduced ejection fraction who remains symptomatic despite optimal treatment of ACI, beta blocker, and MRA. So when the patient is on these 3 drugs, still becomes asymptomatic, then we should shift from the ACE inhibitors to the sacubitril valsartan combination. And the level of evidence is a B for this. If you go through what are the guidelines really recommends is, when the patient is symptomatic because of the reduced ejection fraction, then first therapy should be the ACE inhibitor and the beta blocker. And if the patient becomes asymptomatic, then just follow-up is required. If they becomes asymptomatic, then we have to add an MR antagonist. If the patient is asymptomatic and still the ejection fraction is less than 35, then we should go with an ACI and the AR base. And if the patient is in the sinus rhythm, if the QRS duration is more than 130, then CRT evaluation. And if not able to tolerate then ACE, then we can go to the ARB. But even in these drugs, if the patient becomes asymptomatic, then it becomes an indication to shift to the RNA. Now, how we have to started this RNA is a well-known fact, but it requires a reiteration because many of the people will start earlier than the recommended ones. The patient need to be screened for hypotension risk factors. For hypotension should be carefully assessed and proactively managed before initiating the therapy. So in a cardiogenic shock patients, it is not indicated to start it. We should see that the blood pressure comes to the normal before doing it. And dizziness, hyperkalemia, and the renal impairment or cough are the side effects, and it has to be explained to the patient because they may think that it is related to the drug and they may stop it immediately. And angioedema in the history is there, especially with the enalapril, we can't give even for the neprilysin. Initial dose should be as a replacement it should not be used as a replacement for the ARB medication. There should be a washout period of 36 hours. After stopping of the ACR ARB for 36 hours, then we can start this drug. And then switching from an ACE to ARB to RNA therapy, the initial dose should be similar to the currently prescribed regimen. For example, if the patient has the low dose of enalapril, then we should start the RNA at the dose of 25 by 26 mm twice daily. And up titration has to be done after the 2 to 4 weeks, depending upon the hyperkalemia monitoring and hypotension. If it is not there, then we can uptitrate it and go to the 97/103 milligrams twice daily. The actual schedule is slightly different in the different circumstances. It is worth paying attention to this table because if there is no, it is naive patient not taking an AC inhibitor ARNI, then directly we can go to the 49 milligrams by 51 milligrams twice daily regimen. If currently only taking a low or a just targeted dose of AC inhibitor, then we have to start the ARNI at a low dose, that is 24 milligram by 26 milligrams twice daily. If the patient is a no AC inhibitor, no ARB in the past, it is better to start as a 24 milligrams by 26 twice daily, then uptitrate it. If the patient EGFR is less than 30 also, then we should start at the low dose. It requires a monitoring much more frequently than when the patient has a normal GFR. And the moderate hepatic impairment is there, then also it's better to start at the low dose as well as in the elderly patients. And why we have to do the uptitration to the higher dose? Many people think that if the patient becomes symptomatic at the lower dose, we can continue the same. Then why we have to uptitrate it? This is the study which is demonstrating that autonomic abnormalities because of the heart failure will be decreased only when it is uptitrated to the effective dose. When the same dose is maintained, by the Holter recording, it is demonstrated that there is no improvement in the autonomic cardiac tone. And the major problem is what biomarkers has to be used. As we already know, it inhibits the natriuretic peptides degradation. So automatically it is expected that all the natriuretic peptides are going to be increased. And for a heart failure or impending heart failure, it depends upon the increased levels of the NT-proBNP or proBNP levels. So how can we distinguish whether it is because of the drug effect or a impending heart failure? Even in this condition also, the proBNP is going to be effective. That's what I am going to show the evidence for that. Levels of urinary cyclic GMP and plasma BNP were higher during the treatment with ARNI than with enalapril, but circulating levels of NT-proBNP and troponin levels were lower during the treatment with ARNI than with enalapril. The difference between the groups were apparent within 4 weeks of starting the treatment and are sustained at 8 months. So the same thing is represented as a bar diagram in this, the changes of the NT-proBNP and the troponin levels both in ARNI and with enalapril. If you take the BNP, CNP and the soluble NEP, these will be combined with the receptor which is present on the endothelial layer, and they were internalized and inactivated by the endocytosis. When sacubitril valsartan is given, this site will be blocked and ANP, CNP, BNP levels will be increased. Simultaneously, it will act on H2 receptors and causes the blockade. So these ANP levels will be maintained in the circulation. So based on the available data on the effects of sacubitril valsartan on the BNP and NT-proBNP, the interpretation of the NT-proBNP testing in heart failure appears to be unaffected by the degree of the NEP inhibition. However, the relative increase in the BNP plasma concentrations reported in the paradigm heart failure trial was also the modest. That means the BNP levels usually 200 nanograms per liter, and it is about to median of 225 nanograms per liter is sacubitril valsartan. So BNP concentration greater than 500 nanograms per liter, the frequently used rule in the decision limit of the heart failure, whereas a rate 75% of the BNP concentration in sacubitril valsartan were approximately to the 450. So that's why the cutoff point is taken as more than 500 nanograms per liter of a BNP levels says that the patient is in impending heart failure and requires a up-titration of the other drugs along with this. So it is very safe and it is very easy that when the patient is on neprilysin inhibitors also, we can monitor the pro-BNP levels to know whether the patient is in the impending heart failure or not. The high negative predictive value of exclusion of the heart failure for the BNP testing will obviously be maintained in the patients with the RNA treatment also. After the initial modest rise, which is markedly smaller than in the case of the cardiac decompensation, BNP may reach a new steady state during RNA treatment and then begin to drop long term if marked clinical improvement occurs. If one wants to use the BNP for the disease monitoring in patients, it is advisable to measure BNP about 1 month after starting the RNA treatment to obtain a new baseline value for a subsequent heart failure monitoring. By contrast, for the disease monitoring of the patient with the chronic heart failure on valsartan, the current concept of lower the anti-pro-BNP results, the better the prognosis will always be remain true. If was then suggested to use an increased BNP to define who might be respond to the RNA or to assess the patient compliance. The potential of the pro or anti-pro-BNP ratio for chronic heart failure monitoring with valsartan may be further investigated. In the acute failure, we are very certain, but in the chronic heart failure, probably we may require a different cutoff points than the existing one. And there is a controversy. Should we do only the anti-pro-BNP, pro-BNP levels to detect the heart failure or to know the efficiency of the RNA? There is one study which is published in the March 2019 in the JACC, says that the different types of the natriuretic peptide levels are also studied on the patients who are on RNA. The average time of the follow-up for the 3 months for them. So ANP rapidly and sustainedly increased with the initiation and the titration of RNA, and increase was sustained. Treatment with an RNA is inconsistent with the BNP, whereas concentration of the MR pro ANP, NT pro BNP, and pro BNP 108 variety declined after the treatment. CNP, which is a natriuretic peptide of the vessel, concentration showed no constant change. So I think even though you wanted to use other natriuretic peptides as a substitution of the pro-BNP, still it is not a consistent when the patient is taking on the sacubitril. So it is better to be stick on to the anti-pro-BNP levels only to monitor for the impending heart failure, even though the patient is on RNA treatment. Well, it has very long-term side effects. Everyone talks about the hypertension and the hyperkalemia, which is an acute, which is correctable. So is it possible to have the long-term effect? Only the one study has demonstrated the cognitive impairment. The risk of the long-term side effects of RNA, such as the cognitive dysfunction or Alzheimer's disease, remains to be the unknown. Is this really the contributing or not? We are not yet certain at present. But one fact is that neprilysin, encoded by the NEP or MME gene, is a principal peptidase involved in the degradation of the beta amyloid protein. The several studies have demonstrated that polymorphism of the NEP gene may be associated with the Alzheimer's and cerebral amyloid angiopathy. So in future, probably genetic testing and the genetic genomic testing for the NEP polymorphisms may play an important role for the monitoring the long-term effects of RNA-treated the heart failure patients. In conclusion, I wanted to say that RNA is very effective in the heart failure, and it has to be up-titrated to the effective dose. That is the most important, to have the sympathetic effects to be blocked. And the second important thing is the long-term side effects are very, very rare. And only the one concern is about the cognitive impairment, which may be an incidental or it may be a genetically predisposed person. It may then occur. And the third one is we can still use anti-proBNP levels for a monitoring of a heart failure patients for a detection of a impending heart failure. We need not to fear that this is just because of ARNI treatment. ARNI causes a slight increase in anti-proBNP, but not up to the extent of the higher levels in the heart failure. So monitoring is the best method is by the anti-proBNP. Thank you.